two,
Great. Hi,
two and a
everyone.
half.
Welcome to our first Y.E.S. series of 2026. My name's Amy. I work at the North Suburban YMCA. Today we have a wonderful topic, compassionate care. It's palliative versus hospice care. It's presented by Patti Muray. Patti's a board certified adult nurse practitioner. We have Patti. This is a presentation sponsored by EuroCare, the Weinberg Community Center for Senior Living, CJE Senior Life. On behalf of the North Suburban YMCA, we thank you so much for being here. And we are excited to learn along with everyone here. And Patti, I'll let you take it away.
Wonderful. Thank you so much for the beautiful introduction. I have no disclosures or conflicts of interest to disclose at this moment. So our objectives, we're going to define what's palliative care and what's hospice care, and look at the key difference in the goals of the two disciplines, if you will. We're going to explain how both assist in improving quality of life at different stages in life. And then we're going to discuss some misconceptions related to hospice and palliative care. So, what do I mean when I say palliative care is different than hospice care? Many people blend the two, not understanding they are totally different. So, this is a very common disease progression continuum of illness slide that many people use for explaining. And I like this slide because it puts life on a picture, if you will. So if you look where the arrow is, you're looking at diagnosis, and we're looking at curative or life prolonging. My best example for that is a kiddo who comes in and has appendicitis, or an adult with appendicitis. Easy peasy. We go in, we take out the appendix, we've cured it, and we've prolonged their life, because if it had ruptured, we would be looking at something different. But we also then, as we age, develop different disease pathologies, if you will, that we cannot cure, such as diabetes, COPD. And in this case, we do treatments that are life prolonging or palliative. They provide quality of life and comfort. As we go along and those diseases progress, because there is a continuum of that illness, whether it's cardiac disease, pulmonary disease, renal disease, are the top ones. Oncology fits in there, but that's a little bit different, and I'll explain that as well. But when we can no longer cure, we've maximized treatments, we may be considering hospice. You never have to go into hospice. You can stay palliative forever. And then after hospice, we have what we call bereavement. Our hospice community supports people for 13 months after death, getting families through those first years, the first Christmas, the first Hanukkah, the first birthdays. And that's a very difficult time for people. So all hospices will support whether you have been a member or not, or under their care. You just call a hospice and they will be happy to help you with support. And that can be for usually spouses or children, even grandchildren, if they're struggling with a loss. So what is palliative care? Palliative care, often called PC, is sometimes called palliative medicine or PM. They are interchangeable. There is a whole discipline under palliative medicine, and it's a team of specially trained professionals who provide another layer of support to both the patient and family when they're facing a serious illness. Notice it doesn't say a terminal illness, just serious. The team may include a physician, a nurse practitioner, a PA, social worker, chaplain, pharmacist. It can also include PT, OT, speech therapy, or a dietitian. So it is very much interdisciplinary based on the needs of the patient and the family. Palliative care is person-centered. So it is all about the person, not the disease. So it's a holistic support of people with a serious illness that is directly impacting their life. We frequently say it's all about what you want for you, what you want done, not what you want done to you. I can do lots of things to people, but how is it going to help them? How is it for them? And this is where frequently I will say to families, just because we can do something, should we do it? Is it the right thing to do at this time in the disease process? And those are things that we identify in palliative and move forward with. So, palliative care in a serious illness. What's a serious illness? Well, it could be any disease with a high risk of dying, one that impacts the quality of life, and the family and the patient determine what is quality of life. It's possibly one with high caregiver burden, such as end-stage Alzheimer's, something that may have permanent damage or impairment to the body, such as a quadriplegic, someone who's had multiple amputations. So it all depends on what's going on, a serious illness. My best analogy or example, if you will, is Maggie Daly. She was cared for by palliative medicine or palliative care at Northwestern for 10 years before she went into hospice. So there is no time limit on following with palliative care. So that is my best example. Some other examples may include a serious illness like metastatic cancer, with or without surgical interventions. Someone who's getting a blood transfusion, which we now call a blood transplant. Stage 4 renal disease, when you're playing with the possibility of dialysis. Should we, shouldn't we? Is it a good idea? Progressive Alzheimer's disease. Alzheimer's is now a disease that encompasses many systems. So it's not just the brain anymore. There are other things associated with it. When we have pulmonary disease, idiopathic pulmonary fibrosis, COPD, when patients have had one or more intubations. Do we want to continue that? What is the risk benefit of it? Again, are we doing something to a patient or for a patient? And those cardiac patients, any patient that is going for a left ventricular assist device, whether it is pending a transplant or that is the destination therapy, we have a discussion. It's part of the guideline. So that is a standard practice. No different than someone who's had cardiac disease, multiple stents, they're not a candidate for a heart transplant or further open heart or grafting or stents. What are we looking at? What's the quality of life? What's important? Palliative care has those discussions because we know the prognosis associated with a serious illness. Palliative is not a diagnosis. Palliative does not mean you're actively dying and terminally ill. Doesn't mean you're going to die immediately. It means you're living with that serious illness, and that illness may be stable, unstable, or completely in remission. People who have had cancer receive treatment, whether it's immunotherapy or ongoing immunotherapy, and they are in remission because of that treatment. Palliative care still follows along with them, just like Maggie Daly. Palliative care specifically manages more than 22 symptoms associated with any serious illness. And we are very good at managing those symptoms to provide quality of life that is important to that patient. It's all about the patient and family needs, not based on your disease or prognosis. So you don't sign up or go to palliative care. Palliative care is a consult service, and it works right along with your curative treatment. And I like this picture on the right-hand side because patients come into us a gobbledygook of what's going on and all the things they've been told. And palliative sits down and sorts that out with, not for, but with that patient and family. You will frequently hear physicians or providers say, "Oh, you're not ready for palliative care." Well, I'm going to flip that on its ear and say, palliative care is a service that helps you get ready. Different in that if you have heart issues, you see your cardiologist. If you have a joint issue, you see your orthopedic surgeon. If you have symptoms that are not controlled or quality of life issues that you need to discuss related to what's important to you, you see a palliative care team, a palliative care person, and they will help you sort that out and strategize It is a service that is paid for just the same as any other consult. So you see your orthopedic, you bill it to your insurance, whatever that is. Palliative care is exactly the same. And what do I mean by quality of life? What does that mean? Well, loosely, it's defined as the personal, subjective perception of how life's going. Are you happy with it? Is the person satisfied with how things are related to their decisions? Did they make a right decision? Frequently, we'll hear about buyer's remorse. I agreed to do something and I wish I hadn't done it. What options do we have based on where we are at this moment? Do we have symptoms that are uncontrolled and interfering with your quality of life, your function, your independence? Do you need to brainstorm of how to communicate with the rest of your team? Do you have life fulfillment? What is it that your disease or your symptoms are stopping you from doing that's important? So palliative asks very difficult questions. Our discussion may include, well, what would make things better? What are you hoping for? How are these symptoms getting in the way of what you want to do? Okay. Identifying in a tickler list that's very fluid, what's important to you today? And that may change as we go along. And what is it that you want to achieve? What would improve that quality of life? People have goals, and our job is to help them articulate that and put it into action. We help you find words to communicate, to identify, and then communicate with your team. If you need our help, we're happy to dialogue with your team and let them know what you're thinking. We do this frequently with someone who's been with a consultative service such as oncology or cardiology for years. And sometimes we can try one more thing. And the patient may not want to do one more thing at this moment. They may be maxed out and they may just need a little respite, but they're afraid of hurting the feelings of their providers. So in that case, we act as a bridge, a go-between, to help facilitate that discussion so that everyone can be on the patient's page, not our page. They hire us to help them make that happen. So, one of the things we talk about are advanced directives, a healthcare power of attorney, or POA. It's similar to preparedness planning. What are the patient's wishes at that time? These are subject to change at any point in time. They are fluid. All we do is redo them. CJC, Senior Life, has a legal department that's available to help with these documents. My opinion is anyone over the age of 18 should have a healthcare power of attorney or a POA. Your parents are no longer making decisions for you once you become of legal age. In the event you have an accident, injury, or not able to speak for yourself, who is making those decisions? And do you have an idea of what you would want? If you can't make those decisions, frequently we'll say, well, what do you want? Sometimes it's easier to say, what don't you want? What have you seen in the past? You've seen a loved one, a grandparent, a family member, perhaps have a stroke. Is there something that you've seen that you perhaps don't want? It's awful for anyone, a parent, anyone, a child, to have to make those decisions in a time of distress or an emergency. This is a time when we want to do things for people, not to people. So, in the event of an emergency, and we always pick an ugly thing like a stroke. We've had strokes happen in young girls who are on birth control at 21 years old. What are you hoping for? What are you hoping to happen? What's most important to you? Okay. How do you define that quality of life? What do you want to be able to do? We're seeing a lot of young people now with cancers, and they are metastatic at the time of diagnosis. So based on that, if you had more time, what would it look like? What's important to you? And those are things that palliative will ask those hard questions. And again, at that moment in time, you may have one answer. 6 months from now, it may be a different answer. We just update and redo that power of attorney. We also talk about advanced directives with CPRs, DNRs. PULSE, which is a physician order for life-sustaining treatment. and it's across the country. Everybody has one. A DNR has several sections that require discussion. Doing CPR is a painful, aggressive, invasive procedure. Your patient or family member will end up with fractured ribs, and the older they are, the more fractured ribs there may be. The sternum will also fracture. So we use this as an example because the original intent of CPR was to save young, healthy people with heart issues. It was not intended for elderly with chronic illnesses such as Alzheimer's disease who are frail and debilitated. Survival, and this is from the American Heart Association, in-hospital survival is 1 in 6. Outside of the hospital, survival is even less, at 1 in 10. And survival does not mean without cognitive deficits. It means return of heart rhythm. So do you or your loved one want an artificial support in any way, either short-term or long-term, such as a feeding tube? We call this artificial nutritional replacement therapy. Again, artificial. Going back to my patient with dialysis, you're trying to figure out artificial kidney replacement therapy. Is that something you would want, either short-term or long-term? Would you want breathing tube placement? Palliative care will ask, based on your current disease and what we know about CPR, if your heart stopped, would you want us to attempt to restart it? Again, based on these statistics and based on where the patient is and their disease process, is that something they would want? And these are the tough discussions that palliative care will have with patients and families. Frequently, we will have families say, and patients, do everything. This is really tough because medical personnel and families and patients all are speaking different languages here with do everything. What does that mean? It's not like TV. It's not like Grey's Anatomy. Do everything means different things to each and every one of us. Palliative care as well as hospice will sit and translate those statements into everything means what in the context of what's going on right now. And what would it look like to do everything for your loved one? Sometimes they think that just because Grey's Anatomy got everybody better, that palliative or cardiology is going to make everything better. And that's not necessarily the case. So we will always look to see where is their frame of reference, what context are they thinking about. If you think about it, families do not die at home routinely now, and they're used to the sterile environment of the hospital. And things are very different at home than in the hospital. They don't see a lot of things. They don't see people allowed to have the normal progression of a disease process without intervention. And if they choose to do that, we will help them with what that looks like. So palliative care is good at painting pictures. What would life look like for your mother or father if perhaps you go to the hospital, you have a pulmonary issue or a trauma, a slip and fall at home? We will paint that picture with the good, the bad, and what the in-between will look like. Your loved one is intubated in the emergency room and goes to the ICU. In ICU, that ICU physician, that intensivist, will call for a palliative consult, not because your loved one is dying, but because we want to support you. Palliative care is holistic, patient-centered care with someone with a serious illness, and it's covered by insurance. It's another level or layer of support for someone going through something. So at day 3 in ICU, there's usually a discussion. What are the next steps from a medical perspective? So they update family, the rest of the team. And then around day 10, there's another discussion. They may suggest that breathing tube. Well, they haven't eaten in 3 days. Do we want to do artificial nutrition with a feeding tube? Yes, because they need nutrition. Will we need one after discharge? Is that something your loved one would be okay with based on their life, what's going on and what they've seen. And those are the discussions that palliative care will support the patient and family through. They take into account where the patient and family are coming from and what's important to them. What are their goals? And those may change as we are going along. We have compassionate care decisions to make. The palliative care is trained to ask those hard questions that focus on what the patient would want, while painting a picture of what life would look like, while never taking away hope. Hope never stops. Our hope may change, but we're always hoping for something. And is the plan in line with what the patient's wishes are? Will our decision improve that person's quality of life? Because that's important to us. What would they want? Will the suggested plan cause pain or suffering? And you can always ask for a time-limited trial. Can we try to get a patient off a ventilator? And if they don't, after a certain period of time, a day, 2 days, well, then perhaps we have a different decision to make. We're at a different stage, if you will. What's going on? Where is that disease process? And what are we looking at? So think of an Alzheimer's patient that falls, fractures their hip. Do we want to go to surgery? Do we not? If they're non-ambulatory to begin with, what am I going to provide as far as quality of life by doing that surgery? So these are things that we always ask and fill in those holes with what I call magical thinking of patients and family based on what they see on television. Sometimes then we decide that patient needs the hospice team. And how is that different than palliative? Hospice is a team of passionate healthcare professionals, well-versed in disease prognosis and the trajectory of life-limiting disease. Life-limiting is that the patient is no longer responding to medical or surgical treatment. Or the patient and family may opt for no further treatment. Frequently, patients and families say, I've had enough. I don't want to do this anymore. And the hospice team is a group similar to our palliative, but much more robust in supporting the patient, the family. It's a physician. It can be the primary care, a consultant, or the hospice medical director will take over. It's a pharmacist always, a nurse practitioner, an RN, a social worker, a chaplain, a CNA. We include music therapy, pet therapy, and we have volunteers. We have actually done horse therapy on someone who had a horse. So it's all about the patient and what their needs are. You don't sign up for hospice. However, you do sign a consent, and this is often misleading. Patients think they're signing up for something when they're not. They're signing a consent for Medicare, Medicaid, or personal insurance to pay hospice for the care that is provided. So we're actually contracted, if you will, to provide that care. And just like palliative, where you can cancel at any time, you can do the same thing with hospice. At any point in time, you can say, I don't want hospice anymore. There's a new treatment out. When immunotherapy came on, showed up, a lot of patients with lung cancers, prostate cancers, all discharged from hospice because they wanted to try the immunotherapy. Say you have a patient who's on hospice care and the family says they look really sick. I want them to go to the hospital. I will say to you, that's okay, because that is what you want at this point in time. And this is all about the patient and the family. We will counsel always, is that in line with what you want based on where the disease is? Remember, your family member has a disease process that is life-limiting. Is there something the hospital will do that's not going to cause trauma or distress? And absolutely, you have the right to try it. If it works, Yahoo will discharge you. If you get there, you have a discussion there, and they decide there's nothing else to do, you'll come back home and hospice can take over again. So hospice has a different philosophy and goals of care than palliative. The goals of hospice are to live your best life for as long as possible on your terms. Care is no longer disease focused. So your cardiologist is no longer trying to do different meds. Oncology is no longer doing different treatments. Okay. It's all focused on the patient and what they want and what they don't want. And we do aggressive management of symptoms to maximize quality of life through the end of life, however long that is. Hospice care is an insurance benefit that most of us have with our traditional insurance. It's when someone has decided that that life-limiting disease has a life expectancy of 6 months or less if it's allowed to go the normal trajectory without medical interference. So we let the disease do whatever it's going to do. Medicare has criteria and guidelines that stipulate what the end stage looks like and the prognosis. You will often hear 6-month life expectancy. We generally say 6 months to a year because we do not have a crystal ball. So, hospice care is about living your life on your own terms. So many people live and 25% improve with hospice care. People who improve may be discharged from hospice care because they no longer meet the Medicare 6-month life expectancy criteria. We may discharge them back to palliative care or back to their PCP because they are better. But when you're with hospice, we want that patient to live life on their own terms. That means if they want to stop their low cholesterol diet, that's okay with us. If they want to stop medications that are used as preventive, such as aspirin, I'm not going to prevent anything in hospice. I'm letting the disease take its natural course. You don't like that Lipitor? That's okay. All those vitamins you've been taking, we can stop those too. Patients will frequently say, "Can I go to the hospital?" You can, but many people really don't want to go back, especially if you look at our Alzheimer's who are confused, disoriented. Hospital is not a safe place for them. They get poked and prodded and more disoriented. Okay, so you don't have to go back to the hospital ever again. We can handle and manage all end of life symptoms at home without a hospital intervention. Say you want to travel, you want to go somewhere. If you're still functional enough, go for it. You want to go on a trip somewhere, go visit someone, seize the opportunity. If you are safe to travel, we will help facilitate that. So we're going to go through some hospice palliative myths and debunk them. So, palliative care takes over all your care when you join palliative. No. When you have a palliative care consult, that team works with your primary care or whatever physician team you have. So if it's your primary care, your cardiologist, we work with them, not instead of them. Palliative care becomes another part of your care team. You can have palliative care for as long as you need to, like Maggie Daly was with palliative care at Northwestern for over 10 years. So we follow along. You can still receive aggressive therapy while you are receiving palliative care. Palliative care will not stop your chemo, nor will they replace your oncologist. No one in palliative care is board certified in oncology. We are board certified in palliative medicine, palliative care. Completely different. Myth: you will die sooner if you do palliative or hospice care. The reality is that many people live longer and more comfortably with palliative care and hospice care. Well, how? Well, they live longer sometimes by avoiding treatments. There are less complications, less drug-drug interactions. Patients come in with a long list of medications, and we go through them to see what is providing quality of life. The focus is positive and living the best life possible. The patient is not required to do anything they don't want to do. So if you have a congestive heart failure patient who wants to have a hot dog, they all want to go to opening day of the Cubs or the Sox. Would I let them have a hot dog? Yes, I would. Would I let them have the whole hot dog? No. You can have a bite. You can have a taste. But that gives them quality of life. They want to enjoy life. Patients live longer with nursing care, comfort, and the psychological support that is provided by palliative and hospice care. They experience less worry and less stress that leads to a life well lived. Myth: hospice and palliative are a place that people go. Palliative and hospice can be provided in any setting. It's not a destination. So palliative care can be done in an office. Some of them have office hours, just like your cardiologist. Some of them come to facilities. Most hospitals have a palliative care team that will come see a family member at any point in time. And just because you ask for a palliative consult does not mean you're stopping treatment. It means you are exploring quality of life further and things that are important to you. Myth: hospice stops all of your medicine. It does not. Our focus in hospice is quality of life and comfort. So we will stop some aspirins, or some medications like aspirin, medications that are used perhaps for prevention of something, such as frequently patients who in atrial fibrillation might be on Eliquis, and right now they're sinus rhythm. Well, why do I need a blood thinner? Perhaps I don't. Perhaps I can downgrade that to an aspirin instead of Eliquis, or Coumadin where we have to have blood draws. Medications that do not provide comfort and quality of life, we will discuss stopping them. We never stop medications that are needed for a diagnosis that is not related to your hospice diagnosis, such as if you have thyroid disease and you're on Synthroid, you will continue your thyroid medicine. Medicare will continue to pay for that. That is separate from your Medicare covering your hospice care. So many medications continue despite being in hospice. So any medication that is related to your hospice diagnosis, though, we are required to pay for. So a patient that has Alzheimer's disease, we will frequently be asked if they are end stage, what am I doing with their Aricept, Namenda? Well, if they're end stage and no longer verbal and having quality of life, we will discuss stopping those medications because they are not providing that quality of life. We may not stop them all at once. We may wean them off to make sure there are no side effects as they come off. If a family doesn't want them stopped for a period of time, we may hold on to them for a bit, but that discussion will be ongoing while that patient's disease continues to progress. Are those medications at that point in time providing comfort and quality of life? Myth: hospice and palliative care provide all your care. Well, they don't. Hospice is consultative, just like cardiology. They don't provide any more care. Palliative will see you once to twice a month, depending on what's going on. They do not see you every day. As opposed to hospice, that is a team that sees you as needed. We will see you 1 day a week or 7 days a week, depending on what your needs are. If you need a caregiver, our social worker with both palliative or hospice will assist you in obtaining one. Hospice is available to you 24/7 for emergencies. We will send a nurse out if we need to for hospice care to evaluate, okay? Hospice pays for medication related to your admitting diagnosis. The other medication will be paid for your usual insurance, whether that's traditional retail insurance or Medicare or Medicaid. So we do not take over all your care. Hospice, well, with hospice, you must give up your doctor. Not true. You may keep your primary care physician to coordinate your care. Attendings stay on all the time because they know you better. Some attendings or consultants may want to maintain that relationship and manage care. Sometimes oncology will follow along to manage your care. Some attendings do not have the skill set nor the time to manage end of life. So in that case, they may prefer our hospice medical director manage your care with his team. And that's perfectly fine. If your attendings choose to do that, we will always keep your personal care physician team informed of what's going on with you, especially if something changes. Your palliative care team always sends an updated note to your team, and just like hospice, then will inform them if there are any major changes. Myth: you immediately die when you enter hospice. Well, I like to divide hospice into two stages, early versus late. The early stage, and we prefer the early stages because it allows for planning and getting to know the patients and the families. And in this case, we will say there's a life expectancy of 6 months to a year. We're able to plan, support, maximize that quality of life as things change, and control symptoms. Late stage. Unfortunately, this stage has a life expectancy. It can be hours or it can be to days. And we aggressively manage the end-of-life care in these settings. The patient may be actively dying when they have been referred to us. And our goal then is control of the end-of-life symptoms as that patient is dying and support of the family. And this is a challenging situation if a patient has hours to days because the family doesn't know us and we don't know them. So we prefer to get them earlier and have some time to get to know them, support them, and understand what is important to them. Myth: you must be or have a DNR to start hospice. No, you do not have to have a DNR, but we will go over the fact that performing CPR is an aggressive procedure. So when we do CPR, it's considered a medical procedure. Do you want medical procedures? If you say no, then I'm going to ask you more about performing CPR. What are your goals? We'll have discussions related to advanced procedures. What are you hoping CPR will do? And if we perform CPR and you come back with the same disease you had before and possibly worse, is that okay? Or are you hoping for something different? And what is it that you're hoping for? And we will have that discussion with the patient and the family, and this ongoing discussion. These topics are never a one and done because as the patient and the family become comfortable with their team, whether it's palliative or hospice, we will have further discussions as that trust builds. And we have different partners in our team that may come at this discussion from a different perspective. If a patient stays a DNR, they stay a DNR. And we will do CPR and call 911. Myth: if hospice uses morphine, it will kill you. Not true. The disease kills patients, not the morphine. Morphine is used in many settings, both palliative and hospice care, but is also used if you call 911 and you are having an MI. You have chest pain and shortness of breath. Morphine is given by the paramedics, or even fentanyl now, another opioid, to help offload the heart so it doesn't have to work as hard. So it is not the drug that's the problem, it's the underlying disease. And hospice and palliative are well versed in these medications, as well as converting from one type of medicine to another. Say you come in and you're on one medicine and it's not working well, we may convert you to something else. I like to put this in the context of, have you taken one Norco in the past? One 5-milligram Norco is very small. It's about equal to 5 milligrams of morphine orally. It's just a medication. And we will increase or decrease that medication based on the needs of the patient. How did you tolerate that dose? Do you need more? Do you need less? Did you have side effects? So we'll go with less medicine. Or did it not control your pain or your shortness of breath if you're a cardiac patient, and I may need to give you more? These are all discussions. But again, it's not one drug, and someone always has to give that last dose for comfort. Myth: using morphine causes addiction. All patients, whether you have an addiction in the past or present, are entitled to comfort care at end of life. And that addiction comes in many, many different flavors, if you will. We have addiction to food. We have addiction to chemicals such as cocaine, heroin, alcohol. There are many substance abuse disorders out there. You can also have addiction to social media. There are all kinds of addictions. Coffee. So we care for patients regardless of a history or an active substance abuse. So while you're with us, if you have a history of cocaine, abuse, use, misuse, we will still take care of your symptoms and take care of you. Again, our goals may be different. We may use different medications. But addiction, just so we can have a context for this from our perspectives, addiction is using a substance despite harm or to have a good time. We put safeguards in place in the home or wherever the patient is as needed to keep the patient and families safe. These safeguards are no different than if we have a family at home who's dying of cancer and they're in their 40s or 50s, and we have teenagers in the home. The age at risk for addiction is 16 to 64. So patients who have family members in those age groups, we are very cautious about teaching education, and we may even go to the point of a lockbox. We will do whatever we need to do to keep patients and families safe and decrease the risk of inadvertent use, overuse, or diversion of a medication. Death, it is not death or pain that is to be dreaded, but the fear of the pain or death. This is from Ralph Waldo Emerson. Thank you for your time and attention, and specifically thank EuroCare at your service, who I'm affiliated with, CJE Senior Life. We are also supporting the Gidwitz Place for Assisted Living and the Friends Center for Memory Care. Are there any questions? Again, my name is Patti Muray. I can be reached on email, pmurray, MURRAYCAL, at AOL.com.
Patty, that was wonderful. I learned so much.
Oh, good. I'm glad to hear that.
Yeah, I do have a quick question.
Sure.
Is EuroCare only in Illinois?
Yes, it is only in the North Shore area here, and we provide caregivers in homes or facility as needed.
Okay. And what kind of insurance do you guys take?
For EuroCare,
Yeah.
I do not know the answer to that. I'm
Oh,
terribly.
okay. Yeah. I'm assuming you guys take Medicare and Medicaid and then
I,
probably.
I should have asked our owner that, and I did not think to, because you will find out frequently many people who do clinical do not get involved in the insurance part of it. So I refer them to the office.
That makes sense. I'm
Mhm.
we will make sure that we refer the website and the contact information to everyone that uh watches this video as well.
Wonderful, wonderful.
Yeah. Yeah.
Hey, any other questions y'all can think of?
I would just like to say I'm Marla from CJE Senior Life. Just a quick shout out to Patty for doing such an incredible job. Thank you. And that we've been proud collaborators and partners in the industry for years. So thank you for helping us with this Y.E.S presentation.
You are all very welcome. It was my pleasure.
Yeah. On behalf of the North Suburban YMCA, thank you so much. We hope to see you guys again soon at the next Y.E.S presentation, and we'll have this up on our YouTube series and out and about soon. Thank you.
Thank you.
Have a wonderful day, everybody. Thank you again, Patty. That was beautiful. Thank you so
Wonderful.
much.
Thank you.
Amazing.
Bye,
Great.
everybody.
Good
All right.
job.
All right, ladies.